Today, we highlight exciting news out of the 2016 ASCO Annual Meeting, which was held June 3rd through 7th in Chicago. Welcome to Enclave News Network. I'm Gina Columbus. In breast cancer, a study examining abemaciclib in heavily pretreated patients with refractory hormone receptor positive HER2 negative advanced disease found that the CDK4/6 inhibitor induced a nearly 20% response rate. Results of the single-arm Phase 2 Monarch 1 study demonstrated that patients had a median progression-free survival of 6 months and a median overall survival of 17.7 months when treated with abemaciclib. The most common non-laboratory all-grade adverse events were diarrhea, fatigue, nausea, decreased appetite, and abdominal pain. The grade 3 rates of these events were 19.7% for diarrhea, 12.9% for fatigue, 4.5% for nausea, 3% for decreased appetite, and 2.3% for abdominal pain. Abemaciclib received a breakthrough therapy designation in this setting from the FDA in October 2015. The PD-1 antibody nivolumab demonstrated encouraging signs of activity as a monotherapy in patients with recurrent glioblastoma multiforme, according to results of the CheckMate 143 study presented at ASCO. The multi-cohort study also examined the combination of nivolumab and ipilimumab. In cohort 1 of the study, 20 patients were randomized to receive nivolumab at 3 mg per kilogram every 2 weeks, or nivolumab at 1 mg per kilogram plus ipilimumab at 3 mg per kilogram every 3 weeks. In cohort 1B, 20 patients received nivolumab at 3 mg per kilogram plus 1 mg per kilogram of ipilimumab every 3 weeks. After 4 doses, those in the combination arms went on to receive single-agent nivolumab at 3 mg per kilogram every 2 weeks. The 12-month overall survival rate with single-agent nivolumab was 40%. The median OS with nivolumab monotherapy was 10.5 months, and the adverse event profile was mild. The median OS was 9.3 months in the 1 mg per kilogram of nivolumab plus 3 mg per kilogram of ipilimumab arm, with a 12-month OS rate of 30%. In the 3 mg per kilogram of nivolumab plus 1 mg per kilogram of ipilimumab arm, the median OS was 7.3 months and the 12-month OS rate was 35%. Grade 1-2 treatment-related adverse events occurred in 90% of patients treated with single-agent nivolumab. All patients treated with the nivolumab-ipilimumab combination experienced treatment-related adverse events. Grade 3-4 treatment-related adverse events occurred in 90% of patients in the 1 mg per kilogram of nivolumab plus 3 mg per kilogram of ipilimumab arm, and in 25% of those treated with 3 mg per kilogram of nivolumab plus 1 mg per kilogram of ipilimumab. Based on these findings, a Phase 3 cohort within CheckMate 143 has been opened that will compare nivolumab with bevacizumab for patients with recurrent GBM. In multiple myeloma, adding daratumumab to the standard 2-drug regimen of bortezomib and dexamethasone reduced the risk of progression or death by 61% in patients with relapsed refractory disease. Results of the Phase 3 CASTOR trial showed that the median progression-free survival was 7.2 months in the control arm, but was not yet reached with the daratumumab triplet. The overall response rates were 83% and 63% in the daratumumab and control arms, respectively. When presenting these data at ASCO, lead study author Dr. Antonio Palumbo of the University of Torino said, "This study will open the opportunity to have the combination approach after diagnosis at first relapse. To some extent, we do need evidence before entering a new combination into the treatment arena, but on the other hand, at diagnosis today in myeloma, the remission duration is 5 years. If you double that, you go to 10 years. Today, you have around a 1-year remission at first relapse. If you double that, you go to 2 years. So it is very important to move as fast as we can to get this combination into the early phases of disease where it gives a major advantage." In November 2015, the FDA granted daratumumab an accelerated approval as a single agent for patients with multiple myeloma who had undergone 3 or more prior therapies based on data from 2 open-label clinical trials. The CASTOR study served as one of the confirmatory trials required for full approval. The combination of atezolizumab and the investigational OX40 agonist MOXR0916 showed early signs of safety and anti-tumor activity in patients with solid tumors. At the data cutoff for the study, there were 2 partial responses, one in urothelial cancer, and one in renal cell carcinoma. MOXR0916 is an agonist effector-competent humanized IgG1 antibody against OX40. In the study, MOXR0916 was given at escalating doses, while atezolizumab was always administered at the standard 1,200 mg dose. The incidence and type of adverse events was similar across the various MOXR0916 doses. In the overall population, the most common all-grade adverse events were nausea, pyrexia, fatigue, rash, and chills. The single occurrence of a grade 3 or higher serious adverse event was grade 3 pneumonitis in a patient with non-small cell lung cancer who received 4 cycles of MOXR0916 at 40 mg. The efficacy assessment is continuing in ongoing expansion cohorts for patients with melanoma, RCC, NSCLC, urothelial carcinoma, and triple-negative breast cancer. The expansion regimen dose of MOXR0916 is 300 mg every 3 weeks. In small cell lung cancer, treatment with the delta-like protein targeted antibody-drug conjugate, rovalpatuzumab tesirine, demonstrated single-agent activity and a manageable safety profile for patients with recurrent refractory disease. The objective response rate was 18% across the study population, and stable disease was observed in an additional 50% of patients. In the full patient population that received Rova-T at 0.2 to 0.4 mg per kilogram, the median overall survival was 4.6 months and the 1-year OS rate was 18%. In those with DLL3 high expression, the median OS was 5.8 months and the 1-year OS rate was 32%. When presenting the data at ASCO, lead study author Dr. Charles Rudin of Memorial Sloan Kettering Cancer Center said, "This is a new type of therapy for small cell lung cancer, an antibody-drug conjugate that is biomarker selected. Importantly, this is the first biomarker-directed therapy to be defined for the treatment of SCLC, and this is a biomarker that is expressed in a large majority of SCLC. It may have a lot of utility in the management of these patients." Finally, in ER-positive, HER2-negative breast cancer, the addition of palbociclib to letrozole led to a 42% reduction in the risk of disease progression for patients with advanced or metastatic disease. Results of the Phase 3 PALOMA-2 trial showed that the median progression-free survival was improved by more than 10 months in patients who received palbociclib. The investigator assessed median PFS with the combination was 24.8 months versus 14.5 months with letrozole alone, while the median PFS by blinded independent central review was 30.5 months versus 19.3 months, respectively. The objective response rate was 42% with the combination versus 35% in the control group. The PFS benefit with palbociclib was sustained across subgroups. When presenting the data at ASCO, senior study author Dr. Dennis J. Slayman of the UCLA Health System said, "These data represent the longest frontline improvement in median PFS seen to date in women with advanced ER-positive breast cancer. All subgroups benefited regardless of age, ethnicity, site of disease, prior hormonal therapy, disease-free interval, performance status, visceral metastases status, prior chemotherapy, or prior hormonal therapy." Palbociclib received an accelerated approval from the FDA in February 2015, based on findings of the Phase 2 PALOMA-1 study. The PALOMA-2 results provide confirmation of the benefits associated with the frontline 2-drug regimen. That's all for today. Thank you for watching Enclave News Network. I'm Gina Columbus.